Hello everyone, welcome back to part 2 session about inotropes and vasopressors. Today we are going to present 6 pediatric cases with shock and we are going to discuss together how and what inotropes and vasopressors to start. It is meant to be a two-way discussion, so please feel free to unmute yourself and talk and discuss, and also you can post your answers or opinions in the chat as well. Dr. Ahmed Al-Farsi, who is a pediatric intensivist at Rustaq Hospital, is going to lead this discussion.
Okay, thank you, Dr. Sir, for this nice introduction. And thanks for the audience for their participation in the second lecture in the series of inotropes and vasopressor use in pediatric ICU. So this lecture has been prepared based on the feedback which we received after the first lecture, which was done 1 month back, about the basics and the physiological explanation about the inotropic and the pathophysiological action which we use or we target to achieve when we use such medications. So, our objective for today's lecture, first we will discuss the best choice of inotropes, vasopressor, and different type of shock. So we will discuss different few cases actually of different scenarios, different type of shock, and we will try together to find the best choice of inotropes based on the physiological derangement. Also today we will understand the rationale of choosing inotropes or vasopressors in different case scenario, and we will apply apply your understanding of previous webinar about inotropes and vasopressor in today's discussion. So just a gentle reminder, last month we did part 1 inotropes and vasopressor lecture. For those who attended, it will be good. And for those who did not attend that lecture, you can access it in our YouTube channel. So it will be a good start before participating in today's discussion. So it would be good for those who are listening to this lecture in the record one in the future. For those who are with us today, I will just explain some of the slides which we discussed last time. So it will be a good introduction to understand today's discussion. So to start with, usually when we are at bedside and we are facing a case scenario where there is a discussion for which inotrope we should choose, there is a statement that there is no right or wrong inotrope, but the choices of inotropes, it based on which one is preferred or which choice is better to meet the physiological or to target the physiological derangement in individual cases. So to start with, there is no right or wrong choice, but there is preferred choice based on whatever physiological derangement you have in your patient. So saying that means the choice of inotropes will be based on your cases, based on your finding in your bedside, based on your physical examination, based on your agent finding, if you have, for example, functional echo or point of care ultrasound. So just a recap for what we have discussed last month about the pathophysiology and the understanding of inotropes receptors. So we'll start with arterial oxygen delivery. So as we said last time, that arterial oxygen delivery is usually your target when you have a shocky child or a child who is complaining of poor perfusion. Your target will be to improve oxygen delivery. So oxygen delivery depends on cardiac output and arterial oxygen content. And arterial oxygen content is mainly depend on hemoglobin and saturation. So again, knowing this information, one of your priorities in critically sick patient to make sure that the child is well saturated and his hemoglobin within acceptable range. Then cardiac outputs mainly depend on heart rate and stroke volume. And stroke volume depend on three factors: preload, contractility, and afterload. Saying this, usually at bedside, the discussion will be mainly around blood pressure. We use blood pressure as a surrogate to have a feeling of the adequacy of blood or perfusion to the end organ. But blood pressure, as you know, it is mainly dependent on two factors: cardiac output and systemic vascular resistance. And knowing this fact or this information, your blood pressure alone will not stand in your decision. So you need to integrate blood pressure with your physical examination and with your supportive evidence at bedside, for which, as we said last time, blood pressure, normal blood pressure does not mean good tissue perfusion. So you can get a normal blood pressure, but the child is poorly perfused, and there is already evidence of end organ dysfunction. That's why, because there is two factor playing in blood pressure number with our blood pressure reading, which is cardiac and systemic vascular resistance. The other fact or the other information we have discussed related to the preload. So preload or the intravascular compartment, we can explain it by Frank-Starling curve, which is the relationship between stroke volume and ventricular in diastolic volume. So as simple as the amount of increasing in intravascular compartment, it will be associated or it will be proportionately related to increase in stroke volume, but that increase has a limit. So increasing intravascular volume at one stage will lead to left ventricular dysfunction, and it will be followed by depression or decrease in stroke volume. So your fluid management, it should be targeted to increase stroke volume. But if there is, or if you notice any evidence of compromise in the stroke volume, decrease in cardiac function, or evidence of left ventricular dysfunction, so that is the end point, and the role of increasing the preload or intravascular compartment will be harmful, and it will not benefit your patient. Then we have discussed about the receptors, where the inotropes work, and we use the schematic diagram to explain the receptors we have. So we have a few types of receptors. In the heart, you have beta-1 receptors. So activating or inducing those receptors will lead to increase in heart rate, and it will improve in the contractility. And by doing this, that will lead to improvement in cardiac output. Then there is other receptors, usually in the vascular beds, which is alpha-1 receptors and B1 receptors. Activating of those two receptors will lead to vasoconstriction. And also there is B2 receptors. Activating this receptor will lead to vasodilatation. So knowing those receptors, then applying those receptors to what type of inotropes helping or inducing an effect on different type of receptors, that will lead you to understand what effect I would like to get from activating, for example, alpha-1, or no, I need to activate beta-2 receptor to get the vasodilatation effect that we will discuss in our cases. Also, we said in last presentation that systemic vascular resistance play a very significant role. Usually it increases in case of hypothermia, and if you have increase in transmural pressure. At the end of last presentation, we have explained this diaphragm, which is very simple, but it will give you a clue what type of inotrope and what action I would like to get. So from up to down, we started with vasopressors, uh, vasopressin and phenylephrine, where both those medication will have a major effect on vascular resistance by increasing it, and it has minimal no effect on cardiac output. So it will be a good option for you if you want to induce significant peripheral vasoconstriction without any effect on cardiac output. While going down, the effect of systemic vascular resistance will decrease, but you will get a good effect on inotropy and chronotropy, which lead to increase in cardiac output. So this is what we have discussed in our presentation last time. Let's now proceed with the clinical cases. So in the clinical cases, usually, classically, the discussion was based on agent. So let's say you have a child who presented in different type of shock. Usually the discussion previously was what agent we should start without considering the physiological derangement. And in some units, they are using like a flow or order of inotropes, means sick patients start, for example, dopamine followed by dobutamine, improve well and good. If not, then add epinephrine, regardless of what was the pathophysiological derangement that patient had. So what we are promoting here to use from agent-based selection to action or effect-based selection. So the selection I'll do based on the action I would like to get from that medication and the effect to correct whatever physiological derangement I have. So let's apply this for our cases. So, Dr. Seb, at this stage, shall we ask somebody to participate and read the case, and we'll discuss the case with him?
I think, yeah, if anyone interested, it will be good to go through the case, then to just think what will be the answer of the question, or which the question here on all cases, which inotrope to start
Right.
in the clinical scenario. So
Right.
I will.
Go ahead.
6-month-old child, previously healthy, presented with 5 days history of fever, cough, lethargy, and 1 day history of respiratory distress. On examination, his heart rate is 190, tachycardic, blood pressure is 60/45. His يعني hypotensive كأنه. Temperature is 34.5, so he's hypothermic as well. His saturation is 86 in room air with tachypnea, respiratory rate 70, with delayed cap refill 4 seconds. Chest shows bilateral wheeze, and heart rate has no murmur. Heart has no murmur. Okay. يعني in summary, we're looking at a child with history of fever, tachycardia, hypotension, hypothermia, and tachypnea with delayed capillary refill. So he's in shock, most likely septic shock if he's previously healthy. Given the history of fever, it looks like septic shock.
Good. So let's proceed with the case.
Okay. So given twice 5 ml per kg, normal saline over 30 minutes each. Started on nasal CPAP. After second bolus, you noticed worsening of heart rate to 205, and there was hepatomegaly. Okay.
So what do you think? What has happened to this patient?
يعني the boluses are يعني very minimal, 5 ml per kg over 30 minutes, and over a long time. If we're suspecting a child would give them fast and hard boluses, صح?
Right. So initially you said the child has a picture of tachycardia, hypotension, poor perfusion, and you thought of with fever, and you thought about septic shock. But the child was was managed with IV fluid, but there is a rapid progression in the clinical picture of the patient, where the worsening of heart rate, you expected improvement, and also there was hepatomegaly. While
Yeah.
discussing all those findings, chest X-ray was done, and this is the X-ray of the child.
Okay, so hepatomegaly, once you do note hepatomegaly, you should think of heart failure, and your mind should start thinking about cardiogenic shock as well. So to give like an agent that will help in both the systemic vascular resistance as well as the coronotropy or cardiac function.
Good, excellent. So what type of shock?
So this looks like cardiogenic or septic shock, most likely cardiogenic.
Right.
Yeah.
Right. A child who previously healthy presented with viral illness has poor perfusion, tachycardia, hypotension. Your initial management with IV fluid worsen the clinical picture, so that will bring us and chest X-ray showed cardiomegaly with plethoric line. So this stage, most likely diagnosed for this patient is cardiogenic, most likely secondary to myocardial dysfunction or myocarditis. Okay,
Mm-hmm.
so cardiogenic shock is actually a very complicated pathophysiological changes that occur in your patient. There is so many players, there is so many impairments in the heart itself, in the peripheral vessels, and in organ. So going through all these details will be good to understand the overall impairment and the anticipated complication and the clinical finding based on your intervention. But we will make it simple and we'll follow our previous diagram. So just to explain the effect of giving these two boluses and the worsening in the child condition. So this patient presented with picture of impaired or cardiogenic shock or impaired cardiac function, more fluid, aiming to improve in diastolic volume, initially will improve the stroke volume as per this curve. But in this patient, maybe when we start giving the IV fluid boluses, we are already, for example, at this stage, at the end or at the very end stage where any extra fluid boluses will lead to derangement of the left ventricular function, and it will lead to impairment in stroke volume and decrease in cardiac output. And that's what happened in our patients. With IV fluid, tachycardia worsen and the blood pressure decrease. Okay, good. So you have said again that to improve this patient physiology, you need to improve contractility, correct? Because these patients usually they will present with depressed cardiac function, so they will be tachycardic because of ineffective contractility, or the force or the contractility will be not that strong to generate good cardiac output, for which the compensation will be mainly by increasing the heart rate. And also they will be vasoconstricted, and that evidenced by the clinical presentation where the child is cold, cap refill is very deranged, 5 seconds, and this patient will have poor perfusion. So what type of inotropes you think will be the best to choose for such physiological derangement? Rujane.
As a first line, we should give we can give epinephrine because it works for both. This is my thought.
Right. So
As
epinephrine. Okay, so
yeah.
so here you want to improve contractility, correct? And
Mm-hmm.
you want to overcome the vasoconstriction. So you want to give an agent which lead to improve contractility and decrease the vasoconstriction. So after load will be decreased. So the strength or the resistance the heart need to bump against will be less. That it will be achieved by inducing peripheral vasodilatation. So which one of those inotropes will give you those two effects: increasing cardiac output and contractility, and decreasing systemic vascular resistance by peripheral vasodilatation. So you can see the box here for the inotropes and the effect on cardiac output and stroke volume. Which one you think would be the ideal option to choose in this case?
Dobutamine?
Good, excellent. So dobutamine is one of the agents which improve contractility, and that one of the effect you would like to have in this patient. And also you want to decrease afterload by inducing peripheral vasodilatation. So the resistance, the bump of the heart against less resistance will improve the cardiac output. So dobutamine, excellent, would be one of the best or one of the initial choices you would like to start for a patient who presented to you with cardiogenic shock. Let's say this patient started on dobutamine, you are going up with the dose, but unfortunately still the child has less or decrease in blood pressure, and you are unable to overcome the derangement or the physiological derangement with this shock. Epinephrine, as you said initially, will be another good option in this case, which will lead to augment the contractility, and it will have, with a smaller dose, some vasodilatory effect. But unfortunately, with high doses, it will lead vasoconstriction. So ideally, epinephrine in cardiogenic shock, we prefer to keep or to give a lower dose, not to target a higher dose. So that's in pediatric, but I believe in adult, they don't like epinephrine because of its effect on myocardium and increased oxygen consumption, which can lead to progression of myocardial ischemia. But in pediatrics, still we can use epinephrine as the second agent. Then after that, if you are able to have a good blood pressure and clinically the patient, the blood pressure improved, but clinically still derangement in the perfusion, lactate is not going down, still there is evidence of end organ dysfunction, then at this stage you may target more peripheral vasodilatation to improve end organ perfusion. But at this stage, you need to be, or you need to start with normal blood pressure. So at this stage, milrinone will be one of the good option because it will help in contractility and it will decrease systemic vascular resistance. It will improve end organ perfusion, and it will be a good option to clear lactate and to enhance end organ function. Good, excellent. Thank you, Lujane. Okay, so we will move to our second case. Anybody interested to read the case and run the discussion?
I can go through the case while if someone interested to.
Yes, Dr. Faris, I can read. Okay. We have 6 years old child previously healthy, brought by the EMS after being hit by a car while riding bicycle without a helmet. At presentation, GCS was 7 out of 15, I2, verbal 2, and motor 3, with profuse bleeding from face, ears, and nose. Intubated immediately by ER doctors. Vital signs: he is tachycardic, 170, BP is low, 70/45, MAP is 46, temperature is low, 35, RR is 30, saturating 100, CRT, capillary refill is 3 seconds. On examination, multiple facial fracture with raccoon eyes, nasal and ear bleed, no other significant trauma. So we have a 6 years old with a trauma case, probably has head injury with the skull base fracture, who was already intubated in shock, which can be hemorrhagic shock.
Good, excellent. Proceed.
So the child was managed as severe traumatic brain injury. Brain protective measures started. After 2 IV fluid boluses and blood transfusion, BP is still lowish, 72/46, still low. Yeah.
And at this stage,
Yeah.
CT done, which showed significant cerebral edema,
Edema.
gray matter dissociation, differentiation, and squeezing of the ventricle. So, what is the physiological impairment in this patient?
So we had we have the brain edema, brain injury. So we can have a neurologic shock. In addition, hemorrhagic too.
Okay, so here we have typical presentation of isolated severe traumatic brain injury, which is a very serious condition. Now, this patient already restated with fluid and blood transfusion, but unfortunately, the blood pressure is still on the lower side. So, to understand cerebral perfusion pressure and the pathophysiology, again, you can go back to our channel in YouTube, Oman BCC. There is a nice presentation about cerebral physiology, all the physiological arrangement need to be corrected in such condition. So in traumatic brain injury, the main point or the main target it need to be maintained is mean arterial pressure. So in most of our community ICUs, we don't have neurosurgeon. That means we don't have accurate measurement of intracranial pressure. So in severe TBI, cerebral perfusion pressure would be your target to maintain. In pediatric population, target more than 50 or minimum of 50. That what should be your target. We should not accept less than 50. So only mean arterial pressure is the only target we are able to maintain to overcome the significant increase in intracranial pressure to get adequate or normal cerebral perfusion pressure. So rule of thumb, in traumatic brain injury, we should target higher normal mean arterial pressure. So low blood pressure is a very severe or very bad sign in a patient with traumatic brain injury. So our target will be a normal to higher normal blood pressure to maintain adequate cerebral perfusion pressure to eliminate or to just try to limit any further damage to the brain. So back to our diagram. So in severe TBI, usually you have no problem with the heart unless there is a blunt trauma to the chest or myocardium, but otherwise the heart will be pumping normally. And also there is no significant vasoconstriction or vasodilatation. But our target, as we said in the equation of cerebral perfusion pressure, is to get adequate mean arterial pressure. So Muzna, what do you think? What type of inotropes or pressors you will prefer to improve or to increase mean arterial pressure in cases of traumatic brain injury?
So as you mentioned, we don't have an issue with the heart or the vessels or vasoconstrictions. So we can start with the epinephrine as a start.
Okay, so epinephrine will improve the contractility, which we already said we have no problem with it. Contractility is good, and usually there is no cardiac dysfunction. So epinephrine will lead to inotropy and chronotropy effect, which is good to have it, but I don't have a problem with the heart to start with. But my aim is to improve mean arterial pressure. So I can get that target or that goal by inducing vasoconstriction, causing more constriction to increase mean arterial pressure. So which inotropes you think will be appropriate to use in this case or in this scenario?
Okay, for mainly for vasoconstriction, we can have vasopressin or dopamine.
Right, vasopressin is one of the strong, important vasopressin, but usually it is not the first line vasopressors we use. Before vasopressin, if you can just see with me the
Yeah,
other inotropes, which is readily and we are more familiar to use.
norepinephrine.
Norepinephrine, excellent. So norepinephrine is one of the first choices, will be used in such conditions where you have a traumatic brain injury, isolated TBI, and you want to improve mean arterial pressure. Now the question, you will say that initially you said there is no issue with there is no vasoconstriction to start with, and there is no vasodilatation. And doing or inducing vasoconstriction, it may affect the blood flow to the heart, right? But knowing that autoregulation or cerebral autoregulation, it is a very superior mechanism in the brain cells, where the effect of norepinephrine will be mainly targeted to the less important organ like the skin or the GI system, where vasoconstriction on those arteries and the good autoregulation we have in the brain vessels, that will lead to shift or movement of the blood flow from these less important organs to the more vital important organ, which is the brain. So vasoconstriction, first of all, it will lead to increased mean arterial pressure, and that one of our goals in case of TBI, to overcome increase in intracerebral pressure. And again, it will lead to divert of the blood flow from less important organ like the skin, GI system, to more important organ, which is the brain. So norepinephrine in case of TBI is considered the first line inotropes you can use. If you need more effect, or you need more improvement in your cardiac output and in your systemic blood pressure, then you can proceed with epinephrine. But norepinephrine is usually the first line inotropes in case of traumatic brain injury. Good, we'll proceed to the third case. If no volunteer, then Dr. Saif, we can read the case for us, then we'll proceed with the discussion.
Okay, so this is an 8-year-old girl known to have peanut allergy, brought by parents to ER with sudden history of shortness of breath and difficulty in breathing after participating in birthday party. She already received at home 1 dose of epinephrine via EpiPen, 0.3 milligram, and on presentation, the patient was tachycardic 160, the RR was 60, saturation was 78%, with audible stridor, and blood pressure was low at 70/45, and the MAP was 39.
Okay, good.
So the history of this patient and the clinical picture is very obvious. I wish someone will participate and go ahead and manage or answer the question regarding the physiological impairment and the best choice of inotropes. Who is the champion?
Okay, we will proceed. So the physiological impairment in this case, it's very obvious, as Dr. Saif said. It is an anaphylactic shock where the patient already known to have allergy to a peanut, and from the history, it seemed that she had developed anaphylactic reaction to ingestion of some of the food at that party. So a few review of the pathophysiology of anaphylactic shock and reaction. So it is a very serious condition. It needs a very abrupt and quick action to revert the physiological changes. Clinically, there will be angioedema, skin rash. There will be swelling of the mucous membranes, bronchospasm, cardio or circulatory collapse with low blood pressure. All those signs and symptoms is so fatal, especially because this disorder involves respiratory and cardiovascular system. So management of anaphylaxis, we will not go through all the details of the management, but what is important for us here, the reflex action, if you have a patient with anaphylactic reaction, anaphylactic shock, and he has respiratory and cardiovascular compromise, is IM epinephrine 1 in 1,000 prep, and you can repeat the dose every 3 to 5 minutes. So in this patient, you have given, she was given 1 dose in the birthing by the parents, and when the patient arrived, already 3 doses has been given for the last 15 minutes, but she's still symptomatic. So this patient will fit under the diagnosis of refractory anaphylactic shock, where you can start low dose epinephrine infusion, which is the regular epinephrine concentration 1 in 10,000. And usually they require very small dose. A dose range from 0.02 to 0.1. And usually the symptom will subside. Then inotropes, it can be weaned gradually if there is no more clinical evidence of anaphylaxis. Good, so the simple case, we'll proceed to the case number 4.
Just Rahim al-Ismaili, she said in the chat, so this is basically you need an inotropic support to induce systemic vasoconstriction. So why we choose epinephrine rather than norepinephrine or vasopressor? Since this is
right. So in case of anaphylactic shock, yes, there is, and sometimes it is called distributive shock, where there is some element of vasodilatation and leakage of the blood from the peripheral vessels, but also there is impairment of cardiac output, decrease in cardiac output. Also, there is bronchoconstriction or bronchospasm and laryngo upper airway obstruction because of the swelling of the upper airway. And also you want a medication which suppress the allergic cascade. All those effects will be induced by, or it will be corrected by the use of epinephrine. And that's the medication which you will target to suppress the source of the problem. Air leak, fluid leak and vasodilatation is there, but if you are able to stop the initial cascades of events, then you don't need to treat the end result or the end effect of the initial problem, for which epinephrine will be the best option in case of anaphylactic reaction. If that answers the query, Dr. Steph.
That's true. Also, the epinephrine in anaphylactic shock, it acts through alpha adrenergic stimulation as well. That will counteract the vasodilation effect of the anaphylaxis. So it's also it works in the alpha as well.
Right. Good. So we'll proceed with the 4th case. We may just proceed. 2 years old child, 5 days history of diarrhea and vomiting at emergency. Child severely dehydrated, tachycardic, hypotensive, tachypneic, saturation maintained in room air, poorly perfused with cap refill time of 5 seconds. And as per the mother, there was no urine output for the last 10 hours. So I believe this is the scenario you may have a different degree or stage in your day-to-day practice, as GE and viral infection is common during the season. So this patient received 3 IV fluid boluses, 20 ml per kg each. Then repeated vital signs show still the child is hypotensive, tachycardic. There is some improvement in capillary refill time, 4 seconds, and urine output. It was anuric, but now there is very small urine output, around 0.4 ml per kg per hour. At your institute, you have the facility to do a bedside ultrasound. So an ultrasound of the IVC was done. I may ask for a volunteer to tell me what do you think about the caliber of IVC? It is well distended or it is collapsed? Any volunteer?
It is collapsed.
Good. So IVC is collapsed, and you can know that usually in dynamic studies, you will see the collapsibility of the IVC. And if it is well distended, again, it will be obvious if you have a dynamic study. Okay, so this patient who presented with severe dehydration, you did IVC study and it is collapsed. Now, your resident or the doctor who is working with you during your night, due to persistent hypotension and despite the 3 boluses of IV fluid, want you to start an inotropes. So what do you think at this stage? What inotropes, if you agree with, should be started? Anyone can participate.
Should I start or I can give another bolus?
What do you think? If this is the real scenario and you are the
Yeah, I would, yani giving the significant history of loss and significant history of dehydration, severe dehydration, and giving the supportive picture of a collapsed IVC, I'll give another bolus, and giving that the patient is responding to the bolus is given. With the yeah, there is urine output is coming, and heart rate is trending down, still tachycardic but trending down. So I'll give another bolus.
Good, excellent. So that's usually, or that ideally, the best action it need to be taken. So 3 boluses, usually people stick to 3 boluses, applying what we use in case of septic shock. If you have a child with septic shock, 3 boluses given at that stage, you need to escalate to inotropes. But in case of hypovolemic shock, it's almost hypovolemic shock in a child who presented with severe dehydration. Actually, there is no rule for inotropes. The tank, in layman like the tank is empty, you need to fill it. So 3 boluses may be not enough. Such patients, you may need to give 5, 6, sometimes 7 boluses of 20 ml per kg just to get the balance, and the child will be intravascularly full. So the answer in this patient, give more IV fluid boluses, increase or expand the intravascular compartment. But the role of inotropes will be there if the patient is severely hypotensive. You have difficulty to improve the blood pressure after so many boluses, or there is a delay in applying the fluid boluses, and you think you need to bridge to protect the child from arrest, then at that stage you can consider no best inotropes here, but epinephrine will be one of the options you can start. But the rule of thumb, hypovolemic shock and hemorrhagic shock, you need to give back what has been lost from the patient, either IV fluid or blood.
I have a question. Should we just be guided by the vitals, or should we also repeat the ultrasound to see if the IVC is not collapsed? Like to see if there is a sign for improvement.
Excellent. So usually point of care ultrasound, it is serial study. It is not one study or it's not one moment study. You need to have a serial studies to compare and to see for any improvement or worsening in the child condition. So to look for an IVC, you will have a baseline, you will start your intervention, then you rescan the patient and see. If there is improvement or no, still the patient is empty, I need to give more, then you will proceed That will be one part, and the other part will be the clinical picture and vital signs and all other supportive evidence you have. Apply or collect all together and come in a conclusion. Do not lie on or depend on one study or one intervention. Because usually that is misleading, especially if there is other intervention. For example, if the child on mechanical ventilation and you are guiding your intervention only by point of care ultrasound to look IBC, it may not be helpful for you if the child, for example, on high ventilatory setting. So you need to take the patient as a whole, the physical exam, vital signs, and the other supportive evidence. But to answer your question, yes, you need a serial study to compare pre and after and to look for evidence of improvement or worsening. Good. So we'll proceed to the fifth case. So in case 5, you have 8 years old child presented with 3 days history of high-grade fever, headache, and lethargy. After your physical exam and your assessment, you are suspecting meningitis. The child is tachycardic, hypotensive, with poorly perfused Cabri-fill time of 4 seconds. You resuscitate the child with IV fluid boluses, and after 3 bolus, still the child tachycardic, hypotensive with poor perfusion, Cabri-fill time, still 3 seconds. So what is the physiological impairment here? What we are dealing with? What type of shock?
Septic shock.
Good, excellent. So we are dealing with septic shock. So classically, when we talk about septic shock, the answer will be it is warm or cold shock. So I would like to explain this more because the latest sepsis campaign edition, they do not recommend using those terminology as it is a little bit misleading, and you cannot rely on the physical examination alone to decide either it is warm or cold. But let's go through what is the meaning of each shock. So warm shock, if there is warm extremities, bounding pulses, there is wide pulse pressure, and you will expect a decrease in systemic vascular resistance. Patient will be tachycardic for sure, and that's the situation in cold shock. Tachycardia, but the patient will be cold, clammy, weak pulses, and you will expect in cold shock, there is myocardial dysfunction. So the issue with having those two classification in septic shock is the cardiac function. So it has been found in some cases, in cases of cold shock, most of the time you will expect myocardial dysfunction. So it's a little bit straightforward. But in case of warm shock, you will expect to have a normal cardiac function or hyperdynamic heart. But that's not the situation all the time, because you may get, based on your physical exam, a warm, an evidence of warm shock, but there is depressed cardiac function, for which your choice of inotropes will not be accurate. Because classically, I need somebody to answer. Because classically, what type of inotropes we will use if we have a child with warm shock? Any volunteer? Warm shock, what type of inotropes?
Norepinephrine.
Excellent, norepinephrine. But if I told you I did a point of care ultrasound or a bedside evidence of cardiac function and I found depressed cardiac function, does norepinephrine stand again in your choice, or you want to choose you change your choice for inotropes in case of warm shock and depressed cardiac function?
No, the best option will be adrenaline.
Good, excellent. So for that, the classification for warm and shock without any bedside evidence of the cardiac function is a bit misleading. So I will recommend all of you to, for those especially whom they have an ultrasound point-of-care ultrasound machine in your institute to just have some skills and to learn to use it to screen the heart and just to have the eyeballing of what is the cardiac status. So you can decide child is in warm shock, then norepinephrine if cardiac function is normal. If cardiac function is impaired, then please do not start norepinephrine because it may worse as it will increase the afterload. So epinephrine will be the best option. In cold shock with depressed myocardial dysfunction, epinephrine would be the best option. So that's what we have explained. Again, just to emphasize, depressed cardiac function, warm shock, then you will use epinephrine. Depressed normal cardiac function or hyperdynamic cardiac function with warm shock, then norepinephrine will be the best option. Dr. Saif will move to the last case. Or you think, I think 5 minutes remaining.
Sure. So we have 5 minutes. This is a 4-month-old child known to have large VSD on furosemide and spironolactone, presented with 2 days history of vomiting and not tolerating his medications. He was brought because of increased work of breathing and lethargy. Next slide. So his clinical picture in the ER was tachycardic 160, tachypneic 50, and hypotensive with blood pressure of 60/35 and MAP of 43, and capital time is prolonged at 5 seconds. He was resuscitated with total of 20 ml per kg boluses and started on adrenaline infusion at reached 0.1 mic per kg per minute. And despite that, he was more tachycardic, 180. Blood pressure was 70/40, and the MAP of 50, capital time still prolonged at 5 seconds. He was cold and lactate was 5. He was intubated because of this shock and the chest X-ray, as you can see. So what do you think happening with this child who has VSD? And maybe he didn't take his medication well for the last few days because of vomiting.
Heart failure.
Exactly. So he has heart failure and probably cardiogenic shock. He was started on adrenaline, but despite that, he is still tachycardic. So the adrenaline can cause tachycardia, and still his blood pressure is just borderline, and he is still cold with signs of low cardiac output, with prolonged capital time, and lactate is high. So what do you think? What is causing this, or why still he is still having low cardiac output? You can go to the next slide, Ahmed. So in this patient, remember that he doesn't have normal heart. So he has large VSD. So the patient will have shunt from left to right shunt that is causing more pulmonary blood flow and pulmonary congestion. So that blood going from left ventricle to the aorta, part of it is going to the right ventricle, then to the pulmonary, then it will come back to the left ventricle, then again to the pulmonary. So that is causing low cardiac output. And in this scenario, so in those patients, you need to optimize preload. I will not say increase the preload. You need to optimize the preload. So that means you give fluid, but in small amount and over longer time, to not overload him because he is already having heart failure or pulmonary congestion. You need to, of course, to increase the contractility or improve the contractility, and you already started epinephrine at 0.1 mic per kg per minute. The patient developed tachycardia with that. So with this tachycardia, the ventricle will not have enough time to fill. So that will lead to less steric volume. And we know that he has left to right shunt. So because he is cold, his capital fill time is still prolonged and high lactate, you need to do something to improve the cardiac output, the left ventricle cardiac output. So what should we give to improve that? So as we know now, the left ventricle pressure is high, isn't it? So the left ventricle pressure is higher than the right ventricle. So that's why the patient will have shunt from left to right. How we can improve the blood flow to the systemic circulation?
We have to have some after load reduction.
Excellent. So what will be that? What medication you suggest to start?
So the best option, yes, Myrnol after improving the blood pressure.
Yeah.
Excellent. Yes. So you start milrinone. Milrinone, it is inodilator. So it is inotropic. It has mesotropic effect. So it will allow relaxation of the heart, and also it will vasodilate. When you vasodilate or you reduce the afterload in the systemic, you reduce the systemic vascular resistance. So that means you are helping the heart to pump blood from the left ventricle to the systemic circulation. And by that you will improve the cardiac output, or you will increase the cardiac output. Excellent. As Ahmed said in one of the cases, also you can use dobutamine. It will act in the contractility, and also it will vasodilate as well. Excellent. So I think we reach already to the time. If anyone has any question or to discuss, you can do that. Otherwise, we'll end up here. I think there was a question in the chat, Khalde. She said, is it safe to give 20 ml per kg for cardiac case? The answer, yes or no, and no. So as I said, you need to optimize also the preload. And usually we don't give 20 ml per kg at once. We give like 5 ml per kg over some time. Then we'll examine the patient. We'll assess the patient if develop crackles or hepatomegaly. Then we give another 5 ml per kg and so on. We will not give 20 ml per kg at once in cardiac cases. And also if you have the facility to do IBC assessment, that also will help you. Especially those children, they present with vomiting or diarrhea, or they were not able to take orally for some time. So maybe they have some element of intravascular depletion. So you need to optimize their preload before starting the inotrope. But definitely you will not give them like 40 or 60 or 80 ml per kg as any other patient. You need to restrict the amount of fluid that you are given. Okay, I think Ahmed will end up here. We reached like 1 hour limit, and we hope everyone enjoyed the session. And as we said, we will do this session in monthly basis, and hopefully we will get more presenters to talk about other topics in BICU. And as usual, we make it more practical rather than theoretical.
Good. Thank you.